All right, let's dive right into this explainer. I want to warmly welcome all our medical and surgical students tuning in. Today, we're doing a focused breakdown of what's often called the universal tumor, the lipoma. Whether you're prepping for your boards right now or just getting ready to step onto your next surgical rotation, this is absolutely foundational knowledge. You are guaranteed to use this.
So why start here? Well, just take a look at this number. With a prevalence of 2.1 per 100 people, this is by far the most common benign tumor you are going to encounter. You'll see it in outpatient clinics, you'll feel it during routine physical exams, and you will undoubtedly be pimped on it during ward rounds. Mastering the ins and outs of the lipoma is just essential, not only for acing your exams, but for your everyday clinical practice. To make sure all this information actually sticks, we're going to follow a very logical clinical pathway today. We'll start by defining the ubiquitous tumor, move on to anatomical sites and syndromes, then cover clinical features, differential diagnoses, investigations, and complications, and finally, wrap up with surgical treatment.
Okay, let's jump right into Section 1, defining the ubiquitous tumor.
So what exactly is a lipoma? At its core, it's a benign neoplasm that arises from yellow fat. Really, it's often a combination of neoplasm and hyperplasia. It's composed of mature adipocytes with uniform nuclei that look completely identical to normal adult fat under a microscope, and it carries a karyotype 12q change. But here's the truly fascinating clinical quirk about this. This particular fact is completely unavailable for general metabolism. The body simply cannot tap into it for energy, even if a person is starving. That sets it functionally totally apart from the normal adipose tissue surrounding it.
Now, while your classical lipomas are literally just fat, they can actually mix with other tissues, creating a few variants you need to know. A fibrolipoma, which has fibrous tissue mixed in, is the most frequent variant you'll see, but you really need to pay attention to the ones that cause your patient actual distress. For instance, a neurolipoma involves nerve tissue, making it characteristically painful, or an angiolipoma, which is highly vascular and very tender to the touch. You might also spot navolipomas with telangiectasia, or lipoblastomas, which are benign tumors of immature fat uniquely popping up in the subcutaneous tissue of infant boys.
This brings us to a really fascinating distinction in fat origins. While a standard lipoma arises from common yellow fat, there's actually a rare, benign tumor called a hibernoma that arises from brown fat. A hibernoma has a really distinct reddish-brown appearance and features these serpentine vascular elements. That's a stark contrast to the yellowish-orange, pretty poorly vascularized nature of your classic lipoma.
Moving right along to Section 2, anatomical sites and syndromes.
There's a very good reason it's dubbed the universal or ubiquitous tumor. It can literally occur anywhere in the body. Well, anywhere except the brain. The subcutaneous plane is by far the most common site. You'll see them all the time on the back, the neck, and the proximal extremities. However, deep lipomas can dive right down into subfascial or intramuscular planes. These deep infiltrating variants are highly prevalent in the lower limbs, they often grow to a much larger size, and you'll find they are notably more common in men.
Now imagine a patient presents with multiple lipomas. This actually happens in about 15% of cases, and when it does, we have to distinguish between two key conditions. The first is familial multiple lipomatosis. This one is overwhelmingly common in males. We're talking a 6-to-1 ratio, and it features a diffuse overgrowth of mature adipose tissue. Contrast that with adiposa dolorosa, also known as Derkham's disease. Derkham's presents with really tender, painful fat deposition, primarily in the trunk and girdles, and it is strikingly dominant in females, with a massive 30-to-1 ratio. Interestingly, it's also uniquely associated with epileptic and psychiatric patients.
All right, let's step into the exam room for Section 3, Clinical Features and Signs.
Take a look at this. This is your classic presentation, a large lipoma right on the nape of the neck, which is a super common site. Clinically, when you palpate this, you are feeling for a localized swelling that feels lobular on the surface and is entirely non-tender. These localized variants are perfectly encapsulated. If you were in the OR visualizing this, you'd see that distinct yellowish-orange color. Just notice how clearly it forms a prominent, distinct mass right under the skin.
But, they don't all look perfectly spherical and neat. Over on the left, we have a diffuse lipoma on the plantar aspect of the foot. Diffuse lipomas are completely non-encapsulated. They aren't localized, and because of that, they are notoriously difficult to remove surgically. On the right, we're demonstrating a crucial physical exam technique, the slip sign. Because the tumor is mobile under free skin, its edges will literally slip right away from your fingers when you press on the edge. It's honestly a lot like trying to pinch a wet grape. This is a classic diagnostic hallmark you absolutely must practice on your surgical rotations.
That takes us to Section 4. We need to talk about differential diagnosis and, of course, malignancy.
Here's a fantastic clinical pearl for your wards to help you differentiate a soft lipoma from a slightly firmer soft tissue mass, like a neurofibroma. It all comes down to testing its mobility. A neurofibroma will only move horizontally. It will not move longitudinally along the line of the nerve it actually originates from. You should also be keeping cystic swellings, like a dermoid or a sebaceous epidermoid cyst, in your differential here. But assessing that firmness, the specific mobility, and checking for that classic slip sign we just talked about, that's what's going to guide your diagnosis.
Honestly, visually, benign lipomas can sometimes really throw you for a loop. Check out this remarkable pedunculated variant, which is pretty commonly found in the axillary region. It has that typical lobular surface, but it's just hanging there from a narrow pedicle. Because of where it's located, it suffers from repeated friction, which actually leads to surface ulceration. Clinically, a presentation exactly like this can easily mimic a papilloma. It just goes to show why a careful, thorough examination is absolutely necessary.
And this brings us to a major point of patient anxiety: cancer. Crucially, you have to reassure your patients that benign lipomas do not undergo malignant transformation. Malignant liposarcomas arise de novo, at the mitochondrial level from primitive mesenchymal cells, not from mature fat cells. Having said that, you must always be vigilant for liposarcoma red flags. We're talking rapid growth, a warm surface, dilated veins, infiltration into deeper planes causing restricted mobility, and skin fixation. These are mostly found in the retroperitoneal, thigh, and back, and they demand your immediate attention.
Okay, Section 5, Investigations and Rare Complications.
So how do we work these up? Most are diagnosed clinically, but if you're dealing with a deep, large, or intracavitary lipoma, you're going to need ultrasound, CT, or MRI imaging to properly map it out. That's usually followed by an FNAC or an incision biopsy just to confirm it's benign. You also need to keep a few complications on your radar. Lipomas can undergo myxomatous changes, saponification, or even calcification, which involves mineralization in about 11% of cases. Structurally speaking, if you have a submucosal lipoma sitting in the GI tract, it can actually act as a lead point, causing intussusception and subsequent intestinal obstruction.
Finally, we reach the end of our patient's journey in Section 6, Surgical Treatment and Management.
The definitive treatment for a lipoma is pretty straightforward: surgical excision. Your specific approach is going to depend entirely on your preoperative assessment of the tumor's size and depth. Small, superficial lipomas? Those can be comfortably excised under local anesthesia right in an outpatient setting. However, for those large, deep, or intramuscular lipomas, especially the ones infiltrating the lower limbs that we mentioned earlier, you're going to need to scale up to general anesthesia. That's the only way to ensure proper exposure and safe, complete removal.
But here is the lingering challenge. Despite our absolute best efforts in the OR, the recurrence rate after excision is still 11%. And that rate is especially high in those diffuse, non-encapsulated variants we looked at, simply because it is incredibly difficult to remove every last bit of the tissue surgically when it isn't neatly localized. So it leaves us with a critical question to think about as you step into the OR. How can our surgical technique and our preoperative tissue mapping evolve to ensure the complete, definitive removal of a tissue that so stubbornly blends into its surroundings? Keep that in mind the next time you're scrubbing in.